Meningitis, meningitis, inflammation of the leptomeninges. It can be caused by bacteria, viruses, or rarely fungi. The term aseptic meningitis principally refers to viral meningitis, but meningitis with negative cerebrospinal fluid bacterial cultures may be seen with other infectious organisms, permanential infections, chemical exposure, non-steroidal anti-inflammatory drugs, intravenous immunoglobulin, autoimmune disorders and other diseases, including Kawasaki disease. Causes, bacterial causes, Haemophilus influenzae, Streptococcus pneumonia, Neisseria meningitidis, Group B Streptococcus, Escherichia coli, Listeria monocytogenes, Enterococcus faecalis, Neisseria meningitis, Citrobacter species, Salmonella, Pseudomonas aeruginosa, Staphylococcus aureus. In neonates, the bacteria causing neonatal meningitis are the same as those causing neonatal sepsis. In older children, S. pneumonia and then meningitidis remain the most common causes of bacterial meningitis. Staphylococcal meningitis primarily occurs after neurosurgery or penetrating head trauma. Partially treated meningitis refers to bacterial meningitis complicated by antibiotic treatment before the lumbar puncture, which may result in negative CSF cultures, although other CSF findings suggestive of bacterial infection persist. Here, the etiology can be confirmed by polymerase chain reaction of the CSF. Viral cause enteroviruses, paratroviruses, herpes simplex virus, HSV, Epstein-Barr virus, EBV, cytomegalovirus, EMV, lymphocytic choriomeningitis virus, many arboviruses, HIV, mumps virus in unvaccinated children. Less frequent infectious causes of meningitis: Borrelia burgdorferi, Bartonella henselae, cat scratch disease, Mycobacterium tuberculosis, Toxoplasma, fungi such as Cryptococcus, Histoplasma, Blastomycosis, and coccidioid parasites such as Endostrongylus cantonensis, Naegleria fowleri, Baileys ascaris, and Acanthamoeba. Epidemiology: the incidence of bacterial meningitis is highest among children under 1 year of age, especially infants under 2 months of age. Extremely high rates are found in Native Americans, Alaska Natives, and Australian Aboriginals, suggesting that genetic factors play a role in susceptibility. Other risk factors include acquired or congenital immunodeficiencies, functional or anatomic asplenia, cochlear implantation, penetrating head trauma, recent neurosurgical procedure, and crowding such as that which occurs in some daycare centers or college and military dormitories. A CSF leak, fistula, resulting from congenital anomaly or following a basilar skull fracture, increases the risk of meningitis, especially that caused by pneumonia. Enteroviruses and paratroviruses cause meningitis with peaks during summer and fall in temperate climates. These infections are more prevalent among infants, school-age children, and immunocompromised persons. The prevalence of arboviral meningitis or encephalitis is determined by geographic distribution and seasonal activity of the arthropod mosquito. In the United States, most arboviral infections occur during the summer and fall. Clinical manifestations: signs of meningeal inflammation, headache, of meningeal inflammation may be minimal, with only irritability, depressed mental status, and or poor feeding present. Focal neurologic signs: seizure, arthralgia, myalgia, metalgia, or purpuric lesions, sepsis, shock, coma. Symptoms of increased intracranial pressure: headache, diplopia, ptesis, tinnitus, bulging peritoneal may be present in infants. Papillar edema is uncommon unless there is occlusion of the venous sinuses, subdural lymphedema, or brain abscess. Laboratory and imaging studies: one lumbar puncture, LP, if bacterial meningitis is suspected, unless there is evidence of cardiovascular instability or of increased intracranial pressure due to the risk of herniation. CSF examination is performed to determine white blood cell count with differential protein and glucose levels and gram stain. CSF culture is also performed for bacteria and, when appropriate, fungi and mycobacteria. Polymerase chain reaction is used to diagnose bacteria as well as viral meningitis. No, peripheral leukocytosis is common, and blood cultures may be positive depending on the organism and whether there was antibiotic pretreatment. CSF should be obtained prior to empirical therapy. However, antibiotics should not be delayed if there is an inability to perform an LP. If imaging is required prior to the LP, blood culture should be sent and antibiotics started prior to a completed mammography scan.
Differential diagnosis: encephalitis, trauma, hemorrhagic rheumatic diseases and malignancies. Seizures can be associated with central nervous system, CNS. Infection or can be the sequelae of brain edema, cerebral infarction or hemorrhage, or vasculitis. Treatment: supportive treatment, treatment of dehydration, shock, disseminated intravascular coagulation. Syndrome of inappropriate antidiuretic hormones, seizures, increased intracranial pressure, apnea, arrhythmias, and coma. Maintenance of adequate cerebral perfusion in the presence of cerebral edema. Definitive treatment: initial antimicrobial therapy by age for presumed bacterial meningitis. One newborn. Recommended treatment: ceftazidime plus ampicillin with or without gentamicin. Alternative treatments: ampicillin plus gentamicin. Two infants and toddlers, 4 years. Recommended treatment: ceftriaxone plus vancomycin. Alternative treatment: cefepime plus vancomycin. Children and adolescents, 5-13 years. Recommended treatment: ceftriaxone plus vancomycin. Alternative treatment: cefepime plus vancomycin. Note: due to increasing S pneumonia resistance on empiric third generation, cephalosporin plus vancomycin should be administered until culture results and antibiotic susceptibility testing are available. Ceftazidime, cefepime, or ceftriaxone are also adequate to treat meningitis, H. influenzae, and some E. coli. For infants younger than 2 months of age, ampicillin is added to cover the possibility of Listeria monocytogenes. Duration of treatment is 5-7 days for meningitis, 7-10 days for H. influenzae, and 10-14 days for S. pneumonia meningitis caused by negative. Bacilli should generally be treated minimum 21 days or 14 days beyond the first negative CSF culture, whichever is longer. Dexamethasone as adjunctive therapy initiated just before or concurrently with the first dose of antibiotics significantly diminishes the incidence of hearing loss resulting from H. influenzae meningitis. The role of adjuvant steroids for diminishing neurologic sequelae and mortality for pneumococcal and meningococcal meningitis in children is less clear. Complications and prognosis. Complications: syndrome of inappropriate antidiuretic hormones, deafness, seizures, blindness, paralysis, ataxia, hydrocephalus, learning disabilities, behavioral problems. Prognosis: persistent fever is common during treatment, but also may be related to ineffective treatment or immune complex mediated pericardial or joint effusions, thrombophlebitis, drug fever, or nosocomial infection or repeat LP after 48 hours of therapy should be considered for those whose condition has not improved or has worsened. Gram-negative meningitis, and for those who received adjunct steroids, which can interfere with the ability to monitor clinical response. CNS imaging should be considered in children who demonstrate focal neurologic signs or symptoms, or persistently positive CSF culture. CT with contrast or magnetic resonance imaging is used to detect subdural effusions with S. pneumoniae and H. influenzae meningitis or brain abscess associated with gram-negative organisms. Citrobacter cocci produces neonatal meningitis with a high incidence of brain abscess formation. Neurosurgery should be consulted to consider drainage if a brain abscess is present. With current management, the mortality rate for bacterial meningitis in children remains significant, up to 15% depending on the organism. Morbidity and mortality are highest with S. pneumonia of survivors, up to 30% of sequelae as mentioned above. In complications, all patients with meningitis should have a hearing evaluation before discharge, and at follow-up learning disabilities and behavioral problems may be more subtle long-term consequences of infection. To follow up development, poor prognosis is associated with young age, long duration of illness before effective antibiotic therapy, seizures, coma at presentation, shock, low or absent CSF white blood cell count in the presence of visible bacteria on CSF gram stain, and immunocompromised starters. Rarely relapse may occur 3-14 days after treatment, possibly from Paraningil foci or resistant organisms. Recurrence may indicate an underlying immunologic or anatomic defect that predisposes the patient to meningitis. Prevention, immunization, routine immunizations against H. influenzae and S. pneumoniae for children beginning at 2 months of age.